Can't hear me. Microphone check 1 2. Nope, looks like it's working fine. Where they listening on Facebook? Ask how much she's using. Mm-hmm. Listening audience, can you hear me now? Listening audience, can you hear me now?
Yes.
Say it again. Oh, that was screen. How is drug tolerance best described? A, the ability to get intoxicated. B, the need for more of a drug to get intoxicated. C, increased sensitivity to a drug over time. Or D, decreased sensitivity to drug over time. The answer is D. When the drug is used regularly, the body is gradually able to adapt to the effects of the drug. Evidence of tolerance is twofold. One, greater doses of the drug are required to achieve previous effects, and two, doses that would have produced profound physiological compromise or even death are now readily tolerated without untoward effects. In some cases, it has been noted that up to 10 times a lethal dose or even more may be taken without any signs of significant physiological compromise. Tolerance develops as the body seeks homeostasis or a functional state of equilibrium in spite of the presence of the drug. That's why if a client of yours, let's say they're on fentanyl, and they tested positive for fentanyl for, let's say, 11 months, they would need more and more fentanyl to get that same high. But if you touch just a piece of that fentanyl, you would overdose because you've never ever experienced it. Which of the following is not a drug cue? A, a prior drug use setting. Two, drug use paraphernalia. C, seeing others use drugs. Or D, drug avoidance strategies. Which of the following is not a drug cue? D, intense drug euphoria produces extremely intense, emotionally imprinted memory engrams, coupled with long-term changes in the amygdala area of the brain, which operate outside of conscious control. Key euphoric memories become integrally connected to sights, sounds, smells, people, and places previously associated with drug use. The reappearance of any of these past drug cues will often effectively trigger intense, amygdala driven cravings for a drug. Cravings are further intensified by lingering imbalances in brain metabolism patterns, receptor availability, hormone levels, and other hypothalamus and pituitary mediated sensations of dysphoria and distress. The cascading nature of these effects frequently induces a drug use relapse. And so, drug avoidance strategies are not a cue for drug use. What happens as tolerance for barbiturates develops? A. The margin between intoxication and lethality increases. B. The margin between intoxication and lethality decreases. C. The margin between intoxication and lethality stays the same. Or D. Tolerance does not develop for barbiturates. Hmm? Well, yes, they are. C is the answer. While tolerance for barbiturates does develop, tolerance for an otherwise lethal dose only marginally increases and never exceeds twofold. This means that the likelihood of an unintentional fatal dose increases substantially over time as the need for the intoxicating effect pushes that threshold ever closer to a lethal dose. Given the impairments in memory and judgment that typically accompany CNS depressant intoxication, simple forgetfulness can lead to a fatal overdose. Finally, using barbiturates with any other CNS depressant substance, such as alcohol, can result in an additive CNS depression that can readily be fatal. Death most often occurs via respiratory or cardiac suppression. And that's why what happens as tolerance for barbiturates develops, the margin between intoxication and lethality stays the same. What is the most common symptom of Wernicke's encephalopathy? I say it again. What is the most common symptom of Wernicke's encephalopathy? I did this with two of my supervisees this past week. I wonder if they remember. A. New memory formation. B. Loss of older memories. C. Psychosis. D. Confusion. What is the most common symptom of Wernicke's encephalopathy? D. Other symptoms of Wernicke's encephalopathy include poor muscle coordination and oculomotor impairments. That's problems moving the eyes in a controlled fashion. Wernicke syndrome is a short-term condition resulting from vitamin B1, which is thiamine deficiency, typically developing after years of drinking and poor nutrition. Of those with Wernicke syndrome, 80 to 90% would develop long-term psychosis and memory problems, such as Korsakoff syndrome. While poor coordination is a symptom, retrograde amnesia, which is loss of old memories, and learning impairments are among the most classic hallmarks of the condition. Because they are so often found together, the two syndromes are often referred to concurrently as Wernicke-Korsakoff syndrome. Korsakoff syndrome. Hmm? So the answer is, ooh, I put the wrong answer. The answer is B. Then why did I say D? The answer is B, not D. It's the loss of older memory. It was the most common. Hold on now, hold on. So, let's go back. Let me read this again. Confusion is the most common symptom. D is one of the most. together. Short-term development years of drinking the point of does what we did. Long-term psychosis of so yeah, it is D. Wernicke-Korsakoff, it would be confusion. Yeah, it's the Korsakoff syndrome part that has the amnesia. Which of the following condition does alcohol not induce? Steatosis, A, steatosis, B, nephrosis, C, hepatitis, D, cirrhosis. Which of the following conditions does alcohol not induce? B, which is nephrosis. It's B because hepatitis refers to the inflammation of the liver. Alcohol does do that. Alcohol is toxic to all body tissues. Because alcohol must be metabolized by the liver, it is particularly susceptible to toxic effects. Consequently, many heavy drinkers suffer from alcoholic hepatitis, characterized by abdominal pain, nausea, vomiting, and a swollen liver. In more extreme cases, jaundice and bleeding can result. Jaundice is a yellowing of the skin and whites of the eyes. It's from bilirubin, a byproduct of aging red blood cells broken down in the liver that should have been fully metabolized by the liver. Look up a picture of present day Michael Jordan. He has this condition. Spontaneous bleeding occurs because key clotting factors are made in the liver, but production is inhibited by hepatitis. Steatosis consists of fatty deposits in the liver that, if severe, can prove fatal. Cirrhosis refers to the scarring of the liver from alcohol damage, preventing its normal functioning. High blood toxins can cause hepatic encephalopathy, a reversible dementia, if the toxins are reduced. So that's why, which of the following conditions does alcohol not induce? It's B, nephrosis, because it does cause steatosis. It does cause hepatitis. It does cause cirrhosis. What does formication refer to? And no, we're not talking about the thing that Beyonce was talking about. This is something different as it relates to drug and alcohol use. What does formication refer to? A, the creation of free base cocaine. B, sex between two unmarried individuals. C, a sensation of bugs crawling under the skin. Or D, extra pyramidal symptoms of agitation. Do, 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 do. All right. And the answer is C. Chronic users of cocaine, crack cocaine, methamphetamine, and other such stimulants develop a profoundly unpleasant sensation of bugs crawling under their skin. They may even come to believe the bugs are present and needing to be removed. In less severe cases, users may pick at their skin to the point of causing sores and scabs. In more extreme cases, users may cut themselves in a desperate attempt to release the bugs and find relief. The condition is also known as Magnon syndrome and may also be referred to colloquially as coke bugs or crank bugs, and so on. And that's why what does formication refer to is C, a sensation of bugs crawling under the skin. What is or what are the organs most damaged by cocaine abuse? A, the brain, B, the lungs, C, the kidneys, or D, the heart? Right, the answer is D. Considerable medical research demonstrates that cocaine not only causes arterial constriction secondary to the drug's stimulant effects, but it also causes a comative effect, with more cocaine causing increased arterial narrowing, arteriosclerosis, which is artery hardening and plaque buildup. They greatly magnifies this deleterious process. The result is that permanent disability or death due to sudden cardiac arrest or hemorrhagic cerebral stroke is an increasingly real possibility the longer the drug is abused. Finally, cocaine-induced damage to the prefrontal lobes, where behaviors are modified and controlled, often results in impaired judgment, disinhibition, loss of foresight, decisional incapacity, and chronic unpredictability and irritability. And that's why what is or the organs most damaged by cocaine abuse is D, the heart. Which of the following is not a basic chemical class of amphetamines? A, amphetamine sulfate, B, benzodrine, D, dextroamphetamine, or D, methamphetamine? The answer is B. Amphetamines consist of a group of synthetic stimulants chemically similar to the body's natural adrenaline, the hormone released when the body reacts in high threat, fight, fright, and flight circumstances. The three main types are amphetamine sulfate, but commonly known as speed or by its trade name, benzodrine; dextroamphetamine, its trade name is Dexedrine, or colloquially as Dexy's Midnight Runners; and methamphetamine, which is known as methadone or meth, crank speed, or poor man's cocaine, etc. Among the three classes, methamphetamine has the greatest abuse risk due to its extremely intense rush. While some drugs, such as heroin, may be unpleasant at first use, amphetamines are immediately pleasurable to most users. Consequently, meth is second only to marijuana as the non alcoholic drug most abused worldwide. And that's why, which of the following is not a basic chemical class of amphetamines, is benzodrine. Why? Because that's the trade name for amphetamine sulfate. It's not a chemical class itself. In terms of difficulty quitting, meaning dependence, which of the following four drugs ranks the highest? Alcohol, cocaine. I'm sorry, alcohol, A; B, cocaine; C, heroin; D, nicotine. It's D. In terms of difficulty quitting, relapse rates, cravings ratings, and persistent use despite known harm, nicotine is substantially more dependency producing than cocaine, heroin, and alcohol. In terms of withdrawal symptom severity, nicotine exceeds that of cocaine and is only slightly behind heroin. Thus, fewer than 7% of those trying to quit each year will succeed. Given that nicotine use greatly increases the risk of heart disease, stroke, lung diseases, and cancer, nicotine abuse is a serious public health issue. Even only occasional smoking produces lung and vascular damage, and almost one-fifth of all heart disease deaths are linked to smoking. And that's why, in terms of difficulty quitting, dependence, which of the following four drugs ranks the highest, is D, nicotine. In terms of difficulty quitting, I already said that. Which of the following statements below is most correct? A. THC content in all marijuana is about the same. B. THC content in hashish is lower than in a joint. C. content in marijuana is predictable. And D. THC content in marijuana varies widely. Which one is the most correct? D. Historically, the level of delta 9 tetracannabinol, this is called THC, in domestic U.S. marijuana was less than 0.5%. Recent cultivation and crossbreeding practices, however, have changed this, and some domestic marijuana has substantially higher levels. The THC in Mexican marijuana can range as high as 4%, and Sinasemilia can reach concentration as high as 8%. Potency of hashish, which is a cannabis plant resin, can be as great as 10%, and hashish oil may contain as much as 20% THC. Street marijuana producers may be diluted or cut with other adulterants like oregano or catnip, and may also be laced with other undisclosed psychoactive ingredients such as opium or LSD. Unexpectedly high doses of THC or the addition of other psychoactive substances can greatly affect this unsuspecting user in potentially troubling ways. Thus, caution is in order. And that's why, which of the statements below is the most correct, is D. THC content in marijuana varies widely. Regarding substance abuse, what does convergence theory propose? A. Rates of substance abuse among women are converging with those of men. B. All individuals eventually narrow drug use to a drug of choice preference. C. Age is a key factor in eventual substance abuse abstinence. Or D. As individuals age, gender disparities and rates of abuse tend to converge. The answer is A. Convergence theory postulates that substance abuse rates are becoming more equal during the 21st century concurrently. 1.6 men have substance abuse issues as every one woman with such issues. Others, however, suggest the data is flawed, as women are more likely to hide their substance abuse behavior and less likely to see help. Other gender differences include the following. 1. Men externalize accountability. Women internalize self-blame. 2. Issues of self-esteem are more common for women. 3. Treatment barriers are higher as women tend to have pregnancy issues and children needing their care. 4. Women tend to increase substance abuse when depressed, while men are more likely to decrease use. Women prostitute to support a habit. Men turn to selling drugs or other criminal behavior. Marriage is a deterrent to drug use for men, but a risk factor for women. Women drinkers are 4 times more likely to live with a drinker than is a man. And that's why, regarding substance abuse, what does convergence theory propose? The answer is A. Rates of substance abuse among women are converging with those of men. Among psychiatric disorders in the elderly, where does alcohol abuse rank? A. 25th. B. 15th. C. 5th. D. 3rd. The answer is D. Alcohol use disorders rank 3rd among psychiatric disorders of the elderly. Some 2 to 4% of the elderly have a substance use disorder, including alcohol, drugs, or both. Approximately 15% of the elderly with an alcohol disorder will also have a concurrent drug use problem. Due to physical changes of age, researchers recommend only 1 drink per day as the upper limit. Detecting alcohol and drug abuse in the elderly can be difficult as the symptoms are often very similar to other health problems associated with age. Isolation, poor health, panic, or depression often motivates substance abuse in the elderly. Many are ashamed of the abuse and further avoid family and others to hide the problem. Suicide rates climb as people grow elderly, and 25 to 50% of all attempts by the elderly involve alcohol. Some 10% of the elderly misuse their prescription medication, intentionally or accidentally. Substance abuse may greatly complicate a potentially tenuous status for many on complex medication regimens. And that's why, among psychiatric disorders in the elderly, where does alcohol abuse rank? The answer is D, third. Which of the following subcategories of alcohol use disorder onset is not found in the elderly? A. Late onset alcoholism. B. Delayed onset alcoholism. C. Late onset exacerbation drinking. Or D. Early onset alcoholism. The answer is D. Early onset alcoholism refers to an onset of alcohol abuse in adolescent or young adult life. This represents about two-thirds of all individuals with an alcohol use disorder. Late onset exacerbation drinking refers to individuals with an intermittent history of alcohol abuse that only became chronic in late adulthood. Late onset alcoholism refers to individuals with no prior life history of alcohol abuse who develop an alcohol problem solely later in life. This category of alcoholism may be more amenable to treatment than the earlier onset forms. Detoxification can be protracted in the elderly, requiring a longer treatment stay due to the metabolic changes of aging. Group treatment can be complicated by the group milieu, where younger participants may leave the elderly feeling estranged and out of sync with the other participants. Careful efforts at inclusion or an alternative group composed of older participants may be required. And that's why which of the following subcategories of alcohol use disorder onset is not found in the elderly is D, early onset alcoholism. At an initial meeting with a new client, what is the first requirement? A, establish rapport. B, evaluate readiness for change. C, review rules and expectations. Or D, discuss confidentiality regulations. The answer is A. Exploring readiness for change, rules and expectations, or issues of confidentiality may otherwise serve only to induce client anxiety, defensiveness, or rejection of potential treatment outright. The counselor must generate an authentic and safe environment that is conducive to trust and disclosure. This can be achieved from a motivational perspective by assuring the client that he or she will not be told what to do, but rather help will be given in deciding what he or she is seeking to accomplish. A direct request about what has brought the client in can be helpful if they are ready to talk openly. Otherwise, asking about health, work, or family challenges may provide an oblique entry to asking about substance use issues. Like, for instance, how is this affected by your substance abuse? As rapport grows, issues of confidentiality, program requirements, whether or not sessions can be held in spite of intoxication, etc., session length, evaluation of change readiness, and so on, can then more naturally unfold. And that is why, at an initial meeting with a new client, what is the first requirement is A, establish rapport. What does motivational interviewing primarily involve? A, focus confrontation. B, behavioral accountability. C, reality testing. D, supporter persuasion. The answer is D. The goal of motivational interviewing is to help the client discover his or her own desire to change. Thus, confrontation, stern accountability, overt reality testing, and other coercive or argument inducing approaches are avoided. There's five fundamental principles that guide the motivational interviewing process, and they are reflective and empathetic listening. Two, identification of variances between behavior and personal goals. Three, deflection of confrontation or argument to more positive, goal oriented dialogue. Four, redirection of client resistance to desires and goals rather than opposing it outright. And five, nurturing optimism and a sense of self efficacy when confronted with obstacles, challenges, and negative expressions. I'm going to take a 5 minute break and we'll resume when 5 minutes is over. And we're back. All right. Get that, get that out of here. Get that out of here. Get that out. Oh no, I didn't mean to do that. Um, 1 second as we have technical difficulties. Got it. Got it. Go here. We are going to present. We are presenting a screen. We are sharing a screen. Audience window. Okay, we're back. Sorry for the. Oh goodness, I should have looked at my face when I'm doing that. All right. And we're back. Make sure my mic is on. Okay, we're back. What percentage of individuals with a dual diagnosis, which is co-occurring disorders of substance use disorder and existing mental illness, receive treatment for only their mental illness? A, 32.9%, B, 27.6%, C, 12.4%, or D, 8.8%. The answer is A. According to the 2023 National Survey on Drug Use and Health, when individuals have co-occurring disorders, which are dual diagnosis, consisting of substance abuse and mental illness, only 7.4% will receive treatment for both disorders. 32.9% will receive only mental health treatment, and 3.8% will receive only substance abuse treatment. Where mental illness is severe, the existence of a substance abuse problem is particularly likely, like 25.7%. And among individuals with a substance use disorder in the past year, 17.6%, which I think is more, will have a concurrent mental illness disorder. Thus, where either a substance abuse disorder or a mental illness disorder is known to exist, treatment professionals should be particularly careful to screen further and ensure that any coexisting disorder is identified if one exists. And that's why what percentage of individuals with a dual diagnosis, co-occurring disorders, like substance abuse disorder and existing mental illness, receive treatment for only their mental illness is A, 32.9%. And I suspect that that number is probably higher, just not, yeah, the research just doesn't gather as much information as it could. What factors can affect screening instrument validity? A, the screening setting and privacy. B, the levels of rapport and trust. C, how instructions are given and clarified. Or D, all of the above. The answer is D. Experienced counselors and researchers are aware that the setting in which screening occurs, whether that's the home, the office, the clinic, or voluntary versus involuntary facility, can significantly affect the results of any screening tool used. How instructions are given can substantially influence the finding, as poorly chosen words and presenting attitudes can unquestionably taint client thinking, presumptions, and willingness to disclose. The presence or absence of privacy can also be a significant factor, as distractions, fears, or disclosures, or being overheard and other elements can bias the client, and the intake counselor may also can bias in the screening intake process. Further, the levels of rapport and trust between the client and the intake counselor may also alter client perceptions, and consequently, client responses during any screening interview or when completing any screening instrument. New counselors must therefore be alert to these factors and quickly learn to overcome any deleterious influences. And that's why what factors can affect screening instrument validity is D, all of the above. Which of the following functions is not what a certified alcohol and drug abuse counselor can usually perform? A, client screening. B, substance abuse assessment. C, diagnose mental disorders. D, formulate a treatment plan. The answer is C. Certified alcohol and drug abuse counselors, absent additional mental health training and licensure, do not have the credentials and trainings necessary to diagnose mental disorders. They do have the training and certification necessary to diagnose substance abuse disorders and are well within their scope of practice to screen, assess, and otherwise evaluate clients for substance abuse issues and to formulate and carry out substance abuse treatment plans. Because of the frequency with which co-occurring mental illnesses exist within the substance abusing community, certified alcohol and drug abuse counselors can become very familiar and proficient with numerous commonly occurring mental disorders. It can therefore seem natural to broaden the scope of practice as experience grows. However, legal scope of practice parameters do not provide for certified alcohol and drug abuse counselors to diagnose mental illness, and it is essential that they collaborate with other professionals whenever non substance abuse mental health issues arise. And that's why. Which of the following functions is not what a certified alcohol and drug abuse counselor can usually perform is C, diagnose mental disorders. What does the acronym GATE stand for? A, gather information, access supervision, take responsible action, extend the action. Or B, gather resources, access procedures, take clinical notes, extend the intervention. Or C, gather documentation, access contacts, take counsel, extend positive outcomes. Or D, gather the team, access records, take consultation, extend documentation. The answer is A. GATE was established by a consensus panel addressing the evaluation of suicidal ideation and behaviors by substance abuse counselors working with at risk clients. It consists of activities that are well within the practice scope of a substance abuse counselor. Gathering information involves screening for suicidality and observing for warning signs. Screening involves direct questions regarding current thoughts, such as plans, means, or preparations, and any past histories or attempts. Access and supervision or consultation, even if the counselor already has specialized training, ensures issues of risk are fully evaluated. Taking responsible action protects client well-being and safety, and extending the action involves securing follow-up and ongoing monitoring as needed. In this way, GATE fully assesses and addresses suicidality. The final step is thorough documentation to secure a medical and legal record of the care provided. And that's why, what does the acronym GATE stand for? Is A, gather information, access supervision, take responsible action, and extend the action. To which of the following do assessment processes and instruments not need be sensitive? A, political orientation. B, age and gender. C, race and ethnicity. D, disabilities. A, political orientation is not typically a sensitive issue in the assessment process. Comprehensive assessment domains include complete substance abuse history, all substances past or recently used, modes of use, frequency and amounts, full addiction treatment history, when, where, and how long, significant physical and mental health history, including medications and ongoing care needs, suicidality. 4, familiar history and current issues such as marital status and family supports. 5, educational history. 6, employment history and current issues. 7, legal or criminal history, including any ongoing matters such as pending court, probation, parole. 8, emotional, psychological, and perceptual concerns, which are worldwide issues. 9, spiritual or religious issues. 10, lifestyle concerns such as sexual orientation, housing transients, etc. 11, social and economic factors like finances, work benefits, insurance, etc. 12, prior community resource use. 13, cognitive capacity and behavioral function. And 14, readiness for treatment. And that's why, to which of the following do assessment processes and instruments not need be sensitive? The answer is A, political orientation. What are serious mental health symptoms that resolve with abstinence in 30 days or less, most likely due to? A, a resolution of transient situational stressors at home, school, or work. B, a serious underlying mental disorder that temporarily improved. C, substance abuse induced disorders that require continued abstinence. Or D, malingering to manipulate circumstances for underlying goals. The answer is C. Serious mental health issues such as persistent suicidality, delusions, or hallucinations that precipitously resolve with abstinence are most likely substance abuse induced disorders that would not reoccur within a return to the former substance abuse. In like manner, serious mental health issues that do not resolve in an abstinence period of 30 days or longer are likely due to an underlying mental disorder that must be evaluated and properly treated. In certain circumstances, an underlying mental disorder becomes exacerbated by substance abuse. In these situations, some measure of improvement will be noted, but it will fall substantially short of total resolution. This reflects the persistence of the underlying disorder. They will still need appropriate treatment for meaningful resolution of the condition. And that is why, what are serious mental health symptoms that resolve with abstinence in 30 days or less, most likely due to? It'd be C, substance abuse induced disorders that require continued abstinence. Which of the following alcohol abuse screening tests is designed specifically for use with adolescents? A, Cage. B, Craft. C, Masked. D, Audit. The answer is B. This instrument was designed specifically for use with adolescents, drawn upon situations that are common to this age group. The instrument derives its name from the key word in each of the screening questions: driving a car while intoxicated, using alcohol or drugs to relax, feel better, or fit in, using alcohol or drugs when alone, forgetting events that occurred while using alcohol or drugs, requests by family or friends to limit use, and getting into trouble while using alcohol or drugs. The other instruments are audit, which is the alcohol use disorders identification test, the CAGE, also an acronym, needing to cut down drinking, feeling annoyed at drinking criticism, feeling guilty at drinking, and needing a morning eye opener drink, and the MASS, the Michigan Alcoholism Screening Test. And that is why, which one of the following alcohol abuse screening tests is designed specifically for use with adolescents is B, Craft. Which of the following is the most important introductory statement or question to ask in a suicidality evaluation? A. Have you ever tried to take your own life? B. Do you have thoughts about killing yourself? C. I need to ask you a few questions about suicide. And D. Have you ever attempted suicide? The answer is C. It is important to introduce the topic rather than simply launching into questions. In this way, the client can understand for the questions that follow. This introduction should be followed by very clear questions. Screen for thoughts. Have you had thoughts about deliberately ending your life? Screen for past attempts. Have you ever tried to end your life? A past history of attempts greatly increases the likelihood of future attempts. Any affirmative response to thoughts should lead to questions such as, have you had these thoughts for long? What have you been thinking of doing? Have you made firm plans about this? Do you have the pills, for example, that you've been thinking of using? Where a client has begun to formulate clear plans and realistic means and so on, immediate intervention is essential. And that's why, which of the following is the most important introductory statement or question to ask in a suicidality evaluation is C. I need to ask you a few questions about suicide. What is the purpose of screening? A. To prepare the client for program admission. B. To determine client readiness for change. C. To establish client diagnosis and treatment needs. D. To determine the need for placement or referral. The answer is D. The purpose of screening is to methodically review a client's presenting circumstances by which to determine the appropriateness or lack thereof for placement or referral for further assessment and evaluation. Screening tools are also used to identify the presence of, or absence of co-occurring disorders, particularly those that might contribute to substance abuse. Screening tools do not attempt to diagnose or present a co-occurring disorder, but rather to establish the likelihood that one may be present. Where a client presents as potentially having a significant co-occurring disorder, the client is then referred to the proper clinician, such as psychologist, psychiatric social worker, psychiatrist, etc., for further evaluation and diagnosis. Once a diagnosis is obtained, a treatment plan can be formulated that addresses the co-occurring disorder as well. And this will be the last one for today. What is the primary purpose of substance abuse assessment? A. To determine the current level of health deterioration. B. To identify a substance abuser's drug of choice. C, to provide co-occurring disorder diagnosis, and D, to determine the severity of the substance problem. The answer is D. The primary purpose of substance abuse assessment is to develop a full understanding of the severity and extent of a substance user's drug or alcohol abuse problem. However, the assessment process should also identify and explore other closely related issues, such as co-occurring disorders, both mental and physical, significant others, employment and education, finances, and other social and legal concerns. The overarching goal of assessment is to gather sufficient information to establish 1, a working diagnosis of current substance abuse, 2, significant co occurring disorders, 3, the quality and availability of important supports, 4, readiness for change, and 5, all other necessary information sufficient to establish a meaningful and successful treatment plan. And that's why what is the primary purpose of substance abuse assessment is D, to determine the severity of the substance abuse problem. All right. In the chat, any questions? So that was about 27 questions. There was 50, but I'm starting to lose my voice, and I have a podcast recording tonight, so I got to keep it situated for that. Any questions in the chat? Any questions in the room? Do you have a question? All right. If all minds and souls are clear, we'll end this broadcast. I look forward to possibly seeing you sometime in the near future. Be well and be great. Tune in next Saturday at 12 p.m. on the More Than Therapy Facebook page and on the More Than Therapy YouTube page for more questions regarding the test and preparing for the exam. Be well and be great.